Hello and welcome to this training on screening, brief intervention, and referral to treatment, better known as SBIRT, that focuses on medical billing and coding. My name is Brian Wimbigler, and I'll be your guide throughout the rest of this training. I have no relevant disclosures to make regarding the content or information contained in this training. And what you can plan to learn today is basic ways to integrate SBIRT into most clinical settings that is both effective and timely. We'll recognize a few screening tools for substance use and determine a specific patient's level of risk. We'll explore some healthcare common procedure coding systems and other billing opportunities. And we'll try to understand those common billing codes for SBIRT related activities. We'll also take a look at strategies to effectively refer patients to further treatment if the treatment services that you provide are either inadequate or just outside the scope of where and how you practice. So diving right in, what exactly is a substance use disorder? When starting these type trainings, I always like to lay the groundwork so that everyone that's viewing this has a standard baseline knowledge of what a substance use disorder is and how it affects the brain. So a substance is defined as just any substance that basically changes the way the brain thinks or perceives its natural environment. These can be legal, things like alcohol and tobacco that you can buy at any convenience store, or they could be illicit or illegal like heroin, methamphetamine, and cocaine. A substance use disorder is specifically defined as a pattern of substance use leading to negative consequences in a patient's day-to-day activities or life over roughly a 12-month period. So those things that interfere with their ability to get up and go to work, their ability to interact with family and friends, maybe missing their child's dance recitals, piano recitals, baseball games, sporting events, those type activities. And when you look at it as a whole, these are all negative consequences of their substance use disorder. Looking more specifically at the criteria as outlined in the DSM-5, you can see here there are roughly 11 indicators, and 2 to 3 criteria indicate a mild disorder, 4 to 5, a more concerning moderate disorder, and 6 or more, this is a severe substance use disorder. And in that category, we typically term that clinically as addiction. So read through these to yourself, kind of look at them and say, hey, maybe I have a few of these. Or maybe you know someone or one of your patients presenting to you exhibits some of these criteria and has expressed some of these things to you. This might be an opportunity for you to apply one of the screenings that we're going to talk about later and possibly provide a formal diagnosis of substance use disorder and better be able to address that once there's a formal diagnosis. There are a lot of drugs that can be misused and abused. We're not going to talk a lot about each one of these individually, but worldwide, alcohol is the king as far as substance use disorders. It's the most commonly available, it's destigmatized in most countries and nations around the world, and it's just readily accessible. So that substance is by far the most misused worldwide, and then there are others. We're currently in an opioid epidemic here in the United States. And that's on the forefront of a lot of people's minds and providers' minds in terms of how do we effectively and adequately treat pain and avoid those physical dependence and addiction potential of those opioids that our patients may be using. But looking here, here's a general list, not in any specific order, but I did put alcohol at the top intentionally, of some substances that are used, and they might not necessarily constitute a full-blown substance use disorder, but each of these can form some degree of physical dependence and also psychological dependence that can trend towards full-blown addiction. The main thing on this slide that I want you to take away is that a substance use disorder is a primary chronic neurobiological disease. So this changes the way the brain functions. This is a chronic disease, not unlike chronic diabetes or hypertension. And in the clinical setting, we need to be more mindful that this is a chronic disease. It developed over time, and it will take a long time to essentially heal the brain and treat a substance use disorder. Just like any other common disease, hypertension, diabetes, heart disease, any of those things that we commonly treat, and there's not a lot of stigma attached to those. We need to be more mindful and start treating substance use disorders just like we do those to lower the level of stigma and make it more easier for our patients to talk to us about these things that might be negatively affecting their lives. Drug misuse is an easy definition. It's basically using any chemical substance, prescription or non-prescription, for an unintended purpose. Tolerance, that is the body's natural physiological response. So with that, opioids are kind of unique in how they work is because they don't have a ceiling effect. So you'll need increasing doses of opioids indefinitely to maintain the same level of pain control. So your body develops a tolerance and you need more of the substance to produce a similar or equally analgesic effect. So other drugs are just like that. So if you think about heroin, other illicit substances, the body needs more of that substance over time to produce the same effect, and that's because of the way that it's working and modifying the way the brain works. So what exactly is a disease? It's a disorder of structure or function in a human, animal, or plant, especially one that produces specific signs or symptoms. So with musculoskeletal type injuries, that's kind of easy to tell. If you break an arm or a leg, we know exactly what happens, we know exactly where it is, we know exactly how to treat it. So it affects a specific location, and it's not simply a direct result of a physical injury like a broken bone. So with a substance use disorder, that organ or that system that's being affected is the brain. When we look at the brain, just at a high level, there are three basic parts. There's the reptilian complex. That's where your instincts are. This part of the brain develops first during gestation. It controls all of our autonomic or automatic functions. So breathing, for instance, blinking, those things you don't have to think about them. They're automatic. Also, in this part of the brain, that's where our reward system is housed. Our body rewards us for doing things that will keep us alive. So for example, when you're hungry and you eat, that feels good. When you're cold and you find warmth and shelter, that feels good. When you're thirsty and you drink, that feels good. All things that are going to help us stay alive. So anything that is in our best interest is going to provide a rewarding sensation, and along with that reward, there's going to be a representative memory of that situation. So for example, back in the caveman days, if you found a good, clean, fresh water source, you would need to remember where that is. So when you drank that water, it created a memory surrounding that event, as well as the location so that you could find that again. That cave, you have to remember how to get back to the cave. That fruit-bearing tree, you have to remember where that is. So when those rewarding sensations are released in the brain, it also creates a memory so that you can remember how you found that and the situation around that. So when it comes to substance use disorders, those memories can also be termed cravings. So that intense need for a specific substance. And on the next slide, we'll talk about why that need or that craving is so intense and very hard to override. The limbic system is the next part of the brain that develops, And that's where, as a human species, we learn to work together in groups. So that's why it feels better when we're together. And those senses of camaraderie and being together, those also release feel-good chemicals in the brain. And then the last part to develop is the neocortex, or our frontal lobe, and that gives us the ability for those advanced functions like reasoning, judgment, and empathy. When everything's working appropriately, the frontal lobe has the ability to make rational decisions and override some of those cravings and intense feelings that develop from the reptilian complex. But when you're suffering from a substance use disorder, it's harder to do that because of the immense release of those chemicals, and the primary chemical being dopamine that we'll talk about. And when that huge release of dopamine hits, the frontal lobe basically shuts off, and the connections between that front part of the brain and that reptilian complex is diminished. So your ability to override those intense cravings is also diminished, and that's why it's very hard to stop using a substance when someone is suffering from any kind of substance use disorder. So I've alluded to this special chemical in the brain. It's dopamine. It's our feel-good chemical. And when you look at this slide, it's representative of some natural dopamine releases and then some unnatural dopamine releases. And the main thing to focus on in this slide is if at baseline we're at 100, food, that's a 150. Remember, when you're hungry and you eat, it feels good. That releases dopamine. Having a full stomach and finding nourishment is going to be in our best interest and help us stay alive. Video games. So today you might find that your smart device or your phone is somewhat addictive. You're constantly looking at it. You're constantly going through your Facebook feed. You're constantly looking for that validation and those likes. That releases some dopamine, so that can be habit forming. One of the most natural forms and the highest release of dopamine that we can get is during sex. And if you think about it, we have to prolong the human species to persist through time. So we're rewarded for those activities. So if the highest you can get is a 200% release, look at cocaine, amphetamine, methamphetamine. Amphetamines, that's 1,000% release. Opioids are anywhere between 800 and 1,200. And then the ultra-potent methamphetamine that's coming across the southern border from Mexico, that's roughly 1,300%. So if the highest we can get is 200, and then you're having these huge releases, your brain is then modified to think that these unnatural substances are now paramount for your survival. They also create large memories that revolve around that use situation. So the phone number, text message for the drug dealer, the feelings, the people, the places, the things that were associated with that drug use. Those are all triggers. And when you think about the relative size of those memories that create those cravings, those are larger than anything else. The birth of a first child, watching someone graduate, your own graduation, all these great times in history that have released dopamine for you, they're now overridden by these ultra potent high levels. And remember, the frontal lobe is disconnected from that basic part, so it's harder to override those. And it takes time for those connections to reconnect and for the brain to heal. So why are we so concerned about substance misuse and screening for our patients? Well, one example that I use, and it's relative to people that are watching this now because of the changing landscape revolving around marijuana usage. So there's several states that have completely decriminalized it, and it's open for recreational use, so anyone can purchase and use marijuana. So I'm not concerned about those over the age of 25 or other adults developing a marijuana use disorder. because we have functioning frontal lobes and we have the mental faculties and capability to say, you know what, I've smoked too much marijuana today. I have got to get up and go to work. The problem is with kids and children, specifically those under the age of 25, their frontal lobes are not fully developed. So any substance use, whether it be marijuana, alcohol, or other illicit drugs, it slows the development of the frontal lobe at the time of first use. So what factors into that is the age at which they start, how often they're using, and the potency of the product that they're using. All of those play a role on how much it will delay the progression and formation of that frontal lobe. So up until age 25, it's not fully developed. So basically, it's like having a cell phone without a case on it. We put the case on our cell phones to protect it. So if we drop it, the screen doesn't shatter. So basically at age 25, our brains are fully, those connections are myelinated, they've got a protective sheath, they're protected from damage, and they can stand up to the insult of substances easier or better than unprotected brains. So if you drop your cell phone without a case, the screen might shatter or it might crack. And then if you drop it again, then it might get worse and it might shatter. That first drop, it might still work and the screen might work, but it won't be exactly right. And then with each subsequent drop, it gets worse and worse to where when your touch screen doesn't work at all. So basically in that analogy, at age 25, your cell phone has a case and it can survive a drop or two. Before that, it's very difficult for the brain to survive that kind of insult. When it comes to substance use disorders, women tend to be more susceptible to craving and return to use, two of the key recurring phases in the addiction cycle. Due to their reproductive cycles, women also have unique issues such as infertility and early onset menopause that are linked to drug and alcohol misuse. This misuse is further complicated during pregnancy and breastfeeding. Drugs and other substances, including tobacco, marijuana, and alcohol, can pass through the developing fetus and cause harm. The current opioid epidemic is driving cases of neonatal abstinence syndrome, in which babies are born physically dependent on opioids the mother used during her pregnancy. Substance misuse after birth is also a concern for breastfeeding mothers because substances used by the mother can pass to babies through breast milk. We know that women often use and respond to drug use differently and have barriers to effective treatment for their substance use disorders, and those barriers can be as simple as not being able to find childcare or being prescribed treatments that have not been studied or adequately tested on women. Although women often have a shorter history of using drugs like cocaine, opioids, and marijuana, they enter substance use disorder treatment with more severe medical, behavior, psychological, and social problems. This is because, like common with alcohol use among women, substances have greater effects on women due to body composition and size when compared to men. For pregnant women, quitting cold turkey could put the fetus at risk, and she should always ask for medical help to stop or decrease drug use during the pregnancy. I've provided a lot of background. Now let's dive into exactly what SBIRT is. It's a comprehensive, integrative public health approach to the delivery of early intervention and treatment services for persons with substance use disorders, as well as those who are at risk of developing these disorders for the use in common community settings. So the evidence has shown that SBIRT is a Category B recommendation, and it's as effective, if not slightly more effective, than immunizations and cholesterol screenings in terms of improving patient outcomes. SBIRT has a high certainty that the net benefit is moderate, or moderate certainty that the net benefit is moderate to substantial. It's in the top 4 highest ranking preventative services based on health impact and cost effectiveness. So when you're looking at getting the biggest bang for your buck, SBIRT's right up there in terms of improving health outcomes. The first part of SBIRT is simply the screening. This is where you will identify those patients that might have a substance use disorder or be developing a substance use disorder and need a brief intervention or additional clinical interventions. Clinically, SBIRT is a Category B recommendation, meaning that it is as effective as immunizations and cholesterol screenings in improving patient outcomes. There are a variety of tools that you can use. We're going to look at some examples today. I have a list on a subsequent slide of a number of tools and how they're used and who they're effective for. So I encourage you to take a look at these and identify the tool that is right for your practice. Here's an example of an annual questionnaire that can be put into a patient's intake paperwork or simply just reassessed at an annual level. This way you're not specifically singling out any patients. This is something that all patients receive. It's a quick, really easy screening. Any positive answer is a positive screening, and that would involve a more comprehensive screening to develop or determine the exact degree of substance use disorder your patient may have. So this one is for alcohol and illicit drug use. So you can see there the qualifications for a positive answer. And this is just something that's basic. It's easy. And depending on how they answer, they may need an additional screening, as I mentioned, to lay out and categorize where they might be on the spectrum in terms of their substance use disorder. A positive response to alcohol use on the annual questionnaire might prompt the use of the audit, the alcohol screening questionnaire. You can see here, these are some of the questions. It's 10 questions, and based on their answers, they get a score of 1, 2, 3, or 4. That categorizes the degree of how their alcohol use disorder is presenting. So you can see there, it's a simple process. This takes less, it can take less than a minute. The annual screening questionnaire takes merely seconds. So this is something that has a lot of clinical utility, but takes very little time in terms of workflow. And this is something that your patient can complete while they're in the waiting room or waiting in the exam room for the physician to enter. So this is something that doesn't have to add a lot of additional time in terms of workflow and staff resources. So this is something to consider if you're not already providing these screenings in your practice setting. This is an example of the drug screening questionnaire. So on that annual screening that takes just mere seconds, if they have a positive response, they would then be provided this additional screening questionnaire to categorize the level of their substance use disorder revolving around illicit drug use. So just like the alcohol screening tool, this is something that can be integrated into intake paperwork while they're waiting in the exam room, wherever it fits best in your practice. But remember, this is a Category B recommendation, and it vastly improves patient outcomes who may be currently suffering from a substance use disorder or on the cusp of developing a substance use disorder. So these are clinically relevant, they take very little time, and can really positively impact your patient's healthcare outcomes. This slide is just simply for your reference. This lists some common screening tools. It lays out what substances it screens for, what patient ages it's validated for, and how the tool is administered. So these can be clinician administered or self-administered. There are some that cover both adults and children. There are some children and adult specific screening tools, but I encourage you to look at this general list. This is not all inclusive, but list some of the most common ones used in practice and figure out which one fits best into your specific practice. So once a patient has been identified as having a substance use disorder, the next step is providing that brief intervention. So what exactly does that look like? It consists of feedback about that personal risk and framing that in a way that is specific to your patient. So you'll have to develop those motivational interviewing skills that are outside of the scope of this specific training, but we do have those on our website if you're interested. It provides explicit advice on why that patient should change, emphasis on the patient's responsibility for the change. So this is purely patient-driven. You are merely the vessel identifying the use or the substance use disorder, providing your clinical expertise and help and assistance. It's going to be solely dependent on the person to facilitate and enact those change processes and those change habits. It provides a variety of ways to affect that change, and that's where you can come in. So listen to your patients, figure out what motivates them, and create a discrepancy and frame it in such a way that makes them realize, for example, a diabetic patient that wants to walk their daughter down the aisle. Well, if they've already had a toe amputated and they're still not controlling their A1C and their disease is out of control, it's going to be difficult to do that if their A1C isn't lowered. So that's just an example of creating a discrepancy between what a patient really wants and what their goals are in life and how their specific disease state might prevent them from reaching that goal. This takes place in a variety of settings. It can be primary care, it can be at a pharmacy, it can be at a trained behavioral health facility, this can be in a halfway house or treatment facility. This can happen anywhere, but these brief interventions are where you really get to the heart of the matter and discuss it openly with your patient. These can be very difficult conversations. Substance use disorders carry a lot of stigma, so it's the clinician's role to provide a safe, welcoming place to have these difficult conversations. You've got to be very empathetic. You've got to identify and truly relate to the patient. You don't want to be on, a pedestal and be talking down to your patient. You definitely want to be on the same level and have those person-to-person talks and those connections. It needs to be provided for a minimum of 15 minutes, and that's going to be important when we talk about the ability to bill for these provided services. So when it comes to those brief interventions, there are some reimbursement models that exist through commercial insurance, Medicaid, and Medicare. Here are some current procedural terminology codes or CPT codes for alcohol and substance abuse structured screenings and brief interventions for 15 to 30 minutes. You can see those numbers there. It's minimal, but here's the deal. You're probably already doing similar type screenings in your practice, so you might as well be generating some revenue and getting reimbursed for those things that you're already doing. So we'll talk about some current procedural terminology and other codes that you can use in your practice for those screenings and assessments you may already be doing, but not necessarily capturing the revenue generating possibilities. Medicaid uses specific healthcare common procedural coding systems, and although these aren't commonly and widely used, typically they'll pay off CPT codes alone. These are specific codes for Medicaid for alcohol and drug screening. The reimbursements are a little bit lower than the CPT codes, and when you're looking at these reimbursements, these fluctuate on an annual basis, so they can change all the time. So just look through your payer contracts to see exactly what they'll reimburse for and try to go after those things for those value-added services that you're providing to your patients. Here are some other codes broken down based on the specific parts of SBIRT. So you have a screening only code. No one's going to get rich on this, but remember, that annual screening, it takes mere seconds to complete, and Medicaid will pay $3 for that. So if you're integrating those things into your practice, all those dollars add up. And on top of that, when we go to the way things are trending more on outcomes-based medicine, these have been shown, again, to be just as effective as other commonly screened for diseases, diabetes, heart disease, and specifically hypercholesteremia or high cholesterol, and providing annual flu vaccines, needed pneumonia vaccines, and the like. So it's something that you should be considering anyways, but it's definitely a value added to your patient and improves patient outcomes. There's brief intervention only codes, and Medicare has specific G codes that you can use, and we'll talk more specifically on the Medicaid rules, but in general, Medicaid allows for 2 of these annually that they'll reimburse you for. Screening plus brief intervention. So ideally, you'll be able to screen a patient and provide that brief intervention in the same setting, but it's not uncommon for your patients to be coming in for something else. So you might screen them and identify a potential substance use disorder, but you don't have time to address it in that setting. If you do, you can do the screening plus brief intervention codes. But a lot of times when I talk to clinicians or practitioners and clinicians, they identify something and then they'll schedule another focused appointment just for that specific substance use disorder or to address what they found on that screening tool after that first initial visit. Evaluation and management. So typically, patients are going to be coming in for evaluation and management of something else. It might be diabetes, it could be hypertension, it could be management of their heart failure, any number of things that they might be coming to see a provider or primary care practitioner for. So per Medicaid guidelines, 2 screenings per calendar year are allowed, and SBIRT codes may be billed in addition to those evaluation and management codes. So if they're coming in for evaluation and management of another chronic disease state, you can add on using a 25 modifier to bill for those SBIRT services along with what they were already there to address. Code H0049 and H0050 may be billed together. So basically that is the initial 15 minutes and then each subsequent 15 minutes. So if you did 45 minutes, that would be 1 H0049 and 2 H0050s to capture the full 45 minutes and bill for those services that were provided. Looking more at reimbursement, the definition of time, because remember, minimum is 15 minutes for the brief intervention, and when you're looking at that, you really need to know what the definition of that time is. So it consists of the cumulative amount of both face-to-face and non-face-to-face time personally spent by the physician or other qualified healthcare practitioner in the care of the patient on the date of the encounter. It includes activities like preparing to see the patient, so review of tests, charts, etc., obtaining and or reviewing separately obtained histories, ordering medications, tests or procedures, documenting clinical information in the EHR or electronic health record, and communicating with the patient, the family, and or other caregivers that might be there. So a lot of times we think about time as being just the face-to-face interaction, but it also includes those non-face-to-face interactions and the time that it takes both before and after physically being in the room face-to-face with that patient. So keep that in mind, because sometimes we might think, oh, well, I can't bill for this because I only talked to them about this specific issue for 4 or 5 minutes. That's okay, because you might have spent another 5 minutes on the front end and on the back end to get to that 15-minute benchmark. So don't be discouraged because you're in a busy practice and you don't have the time in your day physically to spend 15 minutes with each patient. This is the cumulative face-to-face and non-face-to-face interactions and activity that go on taking care of and managing this specific patient. So selecting specific evaluation and management codes based on medical decision making and how complex those patient cases might be. So when you're looking at this in broad terms, to qualify for a level of medical decision making or MDM, two of the three elements for that level must be met or exceeded. So this is just an example. Those codes on the left side are the most commonly used codes, and those on the right are those kind of weird in between time frames. So those on the left are basically benchmarked at 15-minute increments, and the ones on the right side, so for example a 99212, are between those 15-minute increments. So the ones on the left side are going to be the most commonly used codes. So this breaks down what codes can be used in what areas of SBIRT. So if you apply this to the 5 A's, ask, advise, assess, assist, and arrange, they can be broken down this way during your brief intervention. So when you're starting this, you can ask and assess, that 99420 and the Medicare G0442 codes can be used for this portion of that verbal interaction. The advise, assist, and arrange, you have a lot more leeway as to which codes that you're going to use. And these codes are all laid out on those subsequent slides as to what portion of the interaction they qualify for. But this is just another thing and another tool that you can use. So if you're interviewing a patient, just like with smoking cessation or any other type substance use disorder, the 5 A's can be a very easy way to integrate that brief intervention into that clinical setting, and there's already billing codes in place and categorized for which portion of that 5A intervention that you're applying in the setting of that brief intervention. So you don't have to create your own algorithm or treatment chart to fulfill those brief interventions. Just use methods that are already out there and readily available, like the 5 A's. So ask, advise, assess, assist, and arrange. And remember, the most common place this has been used is with smoking cessation, but it can be applied to alcohol use disorder, opioid use disorder, any kind of substance use disorder. And one really important thing to keep in mind is not every patient is going to be ready to stop or slow down their use. So that's why these codes are broken down specifically in separate ways. If you ask every time and you don't get to the assess, assist, and arrange, that's fine. But you should still be billing for those services that you did provide. Now let's say you've done the brief interventions, you've been working with your patient, and you're just not making any headway. And either the services that you provide in your practice can't adequately meet the demands or the needs of that patient. For example, let's say that you're a practice and you don't have an X waiver, so you can't provide medication to treat opioid use disorder. First, I would encourage you, if you're a physician, to go ahead and get that X waiver. Now, currently in the state of Tennessee, you don't have to do any additional training. You just simply have to register for the XDEA waiver, and you can treat up to 30 patients a year using medications for opioid use disorder or specific medications for addiction. So I would encourage you to do that. But if you don't, you'd really need to know where you can send your patients for additional treatment and care. There are several hub and spoke models that are available in our area. Metro Drug Coalition utilizes the SBIRT software. They serve as the hub, and different practices and practitioners are the spokes. So if you have a patient that might be in need of specific services, you can work with Metro Drug Coalition, enter into the SBIRT software, put in the patient-specific information that is sent to the hub and distributed to all the other providers. And if you have a patient that might need an inpatient bed for their substance use disorder, if there's a provider that has one available, that patient will be linked to that service. So it's just another way that provides you with avenues that when you have a difficult patient or you need additional help or assistance in treating a patient, there are resources available that you can reach out to and lean on to provide the appropriate level of care for your specific patient. So how this works is specialty clinics with broad board certified addiction specialists are in the hub and spoke network. They provide treatment with buprenorphine or methadone depending on the patient assessment. So specifically for opioid use disorder, there are a lot of providers in the area that are regulated by the state. So these aren't like if you remember back just as recently as 5 to 10 years ago, we had a lot of pill mills in our area that have subsequently been shut down, but then we had a lot of those practitioners go on the treatment side. So the treatment side is highly regulated. A lot of the bad actors have been removed, and I encourage you to develop relationships with these addictionologists and treatment centers. So if you choose not to get your XDEA waiver and treat patients for opioid use addiction in your practices, you can send them to really well qualified practitioners in the general area that can take care of these patients. If you are considering getting your XDEA waiver and are just concerned that you might not know exactly what to do and how to work with the patients, I encourage you to attend some of Vanderbilt's ECHO sessions. These are special sessions. It's a telelearning program that covers key aspects of prescribing, psychosocial supports. It talks about motivational interviewing, harm reduction, and how to treat co-occurring disorders. Someone might have an alcohol use disorder and an opioid use disorder. Someone might have bipolar disease and another mental health disorder on top of a substance use disorder. So a lot of these complex cases are discussed. It's a safe, open environment where you can ask questions and get answers from providers that are providing treatment and care to patients that are similar to yours and have been doing this for a long time and have a lot of great information on how you can do the same thing in your clinical practice. It's funded by the Tennessee Department of Mental Health and Substance Abuse Services, and it has a really robust curriculum. So you're not just jumping on an ECHO session and just flying blind. There are set agendas. They go through and talk about specific cases, specific drugs, specific patient scenarios. So it's really a robust community of MOUD providers that are really there to provide expertise and information to those that are wanting to fill those gaps in their community and provide these very needed services. At a bare minimum, in each of your practices, if you have no other information or no other reference or referral type scenario or places that you can send your patients, please, please, please be familiar with your local regional overdose prevention specialists. These are peer recovery support specialists that have been through a substance use disorder on their own and have found recovery, so they can identify and really empathize with the patients that you may have that are suffering from a substance use disorder. They also are very well connected in the community, and they are aware of all of the resources the local community has to bear to help people access treatment, access recovery, and start that recovery journey. So regardless of ability to pay and insurance status, these regional overdose prevention specialists can lead patients to care, whether it be through Metro Drug Coalition, Helen Ross McNabb, other agencies in the local community. The regional overdose prevention specialists provide that warm handoff into treatment. They provide just someone to listen to, and also they are a great source of information on harm reduction, including access and availability to Narcan, the life-saving opioid overdose reversal agent. So for those patients that might need that, they can link them to Narcan or naloxone at no charge. They're also very instrumental in providing information on other addictive drugs, stimulants. So please be familiar with your regional overdose prevention specialists and rely on them and utilize them to help your patients and get them that warm handoff into treatment if you don't have those connections for behavioral health linked directly to your practices. Additional resources that have been around for years, the Tennessee Red Line, basically 24/7. Patients can call that if they're in a moment of crisis. We've got the crisis line as well. You can also text 741-741 to the crisis line and get direct linkage and contact there. There's the Tennessee Recover app. This also will help you link your patients to those regional overdose prevention specialists. You simply text SAVE to 30678. This is basically a social media platform for anyone suffering from a substance use disorder, family or friends who just want more information on understanding what it is, how it's treated, and how it presents. And it really links a lot of people to NA, AA, all those treatment services and community networks that are needed to help provide those wraparound services for people that are struggling from a substance use disorder. With that, that's all that I have for you this afternoon. This is my contact information. Feel free to reach out to me at any time. Email is typically the best way, bwimbiggle@uthsc.edu. I also work a lot with the Tennessee Department of Mental Health and Substance Abuse Services, providing trainings on specific drugs and treatment modalities. So if you are in need of additional information, or you would like for me or one of my colleagues to come speak to your local group, I would be happy to do so. That's my family. That's why I do this, to make sure that when my boys are growing up, that we live in a safe environment, void of a lot of the stigma that's out there now. So heaven forbid they develop a substance use disorder, there are knowledgeable practitioners and people out there that they can turn to get their lives back on track. But those are my three boys. My wife, Jennifer, she's a hospitalist at Blount Memorial Hospital here in our hometown of Maryville, Tennessee. So we bounce a lot of ideas off of each other. So if you are in need of additional information, feel free to reach out to me and I can put you in contact with Jennifer as well. Thank you very much for your attention, and best of luck utilizing SBIRT in your practice scenarios. And until next time.